I'm Julie Duncan-Miller and I'm presenting our Q findings on exploring supported self-management with stroke survivors, practitioners and managers to identify what's most important for making it work. Before I begin, I'd like to acknowledge the funder and our other collaborators on the project, including our patient and public involvement team. Importantly, I'd like to acknowledge the participants who so generously gave their time. Stroke is an acute event, but most stroke survivors experience long-standing physical, cognitive and psychosocial consequences, such as difficulty with movement, communication or emotions, which can have a huge impact on the stroke survivor's life. Stroke is a leading cause of complex disability worldwide. Supported self-management is a recognised approach in supporting people after stroke, and it's a core component of policies and guidance on long-term condition management across the UK and internationally. Despite its importance, it's not exactly clear what supported self-management in stroke looks like and how stroke survivors and health professionals can work together to address stroke survivors' long-term needs. Thus, we undertook a realist evaluation to explore what works for whom and why in supported self-management across community stroke teams in Scotland. A Q methodology study was undertaken as part of this realist evaluation. Combining realist evaluation and Q methodology is relatively novel. We know of only one other project that's combined the two. Realist evaluation involves generating programme theories about how a programme, such as supported self-management, may work. These theories are generated at the start of a realist evaluation using something like a realist review to explain what might work for whom and why under what circumstances. Throughout the realist evaluation, the theories are then tested and developed using the best available evidence. In this project, the Q methodology is being used to further develop and refine the theories before they're tested in the later stages of the realist evaluation. The diagram makes the process look very simple and linear. In reality, it's not. Realist evaluation involves many pieces of the puzzle, but for simplicity's sake, we developed the programme theories before the Q study. Those programme theories informed the Q, and the output of the Q informed the further development and refinement of the programme theories about supported self-management. The aim of this Q methodology study was to explore the views of stroke survivors, clinicians working with community stroke rehab teams and service managers to identify how supported self-management is understood by them and their perceptions of what is most important in making supported self-management work after stroke. For this study, initial programme theories from the overarching realist evaluation project were used to generate statements for the Q set. The initial programme theories were developed from academic literature and expert input. These theories were used to structure the statements, with each statement mapped to a theory. This resulted in 78 statements. Following this, the statement set was reduced by merging similar statements and deleting where overlap occurred. In selecting a final set of statements, it's important to ensure coverage and balance across all initial programme theories. And 32 statements were taken forward to piloting. The project team and the patient and public involvement group reviewed the statements and piloted the Q sort. No further changes were made to the Q set at this stage, and the statements were then printed onto individual cards ready for the Q sort. Here's an example of what was in the Q set. In terms of how the statements are written, we took these from the literature and spoke to experts as part of the realist review, which informed the structure of the statements. We wanted it to be linked to the realist review, and thus the language in the statements is more written than spoken English. In this study, 3 groups of participants were identified. Adult stroke survivors 6 months or longer post-stroke who'd been offered, received or engaged with supported self-management services, clinicians of any profession who were involved in the delivery of community-based supported self-management services for stroke, and managers of these teams in one of the 4 case study sites. We aimed to identify 12 participants in each study site. All participants were identified face-to-face or via letter by local collaborators at one of the 4 Scottish Health Board sites. The Q sorts were administered by me in a face-to-face one-to-one interview for stroke survivors and managers and a focus group for clinicians. Written informed consent was obtained before starting. Participants were given an introduction to the study and the opportunity to ask any questions. Participants were then given the pack of 32 statement cards to read and asked to sort these into 3 initial piles: most important, important and least important. The participant was then guided to refine these initial groups and rank order each statement onto the Q grid from most important, +4 on the grid, to least important, -4 on the grid. Because it was important to ensure that stroke survivors were an integral part of our sample, Our materials were designed with them in mind first before the other stakeholders. Given that stroke survivors often experience difficulty understanding writing or have difficulty processing complex instructions, this format on the grid was deemed the most easy to follow by the PPI group. As you can see from the picture, we flipped the grid compared to how it might be done because we read from left to right, rather than sort with the right hand as other people might do. We've used sans serif text and kept writing to a minimum. Instructions were succinct and to the point. We also printed off an instruction sheet for participants to refer to in case they got confused. We blocked off 1.5 hours to do the interviews to give participants sufficient time. Cards were yellow with black text to aid reading for those with communication difficulties. Following completion of the Q sort, the participants were asked open-ended questions about the statements placed in the +4 and -4 positions on the grid. For interview participants, which were the stroke survivors and the managers, this was asked verbally. And for focus group participants, which were the clinicians, this was asked on paper, since participants completed this Q sort at different times in the focus group. All participants were asked, is there anything else that you want to tell me about the statements in relation to what is important in making supported self-management work for you? As well as general questions about the overall Q sort. We achieved our recruitment target of 48 participants. We've been able to sample from a range of stakeholders, a range of people affected by stroke, and a range of different clinical groups and a clinical experience. We entered data in PQ method and analysed in CanQ. Centroid analysis and varimax rotations were completed. We examined a number of different factor solutions and decided on 4. The 4 factors explain 46% of the total variance. Participants from every stakeholder group loaded onto each factor except factor 2, which was only stroke survivors. Factor 1 is an account which emphasises the importance of a person-centred approach, focusing on the individual's needs and meaningful goals. The person-centred approach focuses on developing stroke survivors' skills and confidence in their abilities to self-manage, building hope and restoring a sense of self-worth. Respondents defining factor 2 emphasised that it was important to listen to the stroke survivor and that they felt cared for and supported. Support came from a wide network, including spouse, family, friends, health professionals and local community organisations. Respondents defining factor 3 emphasised the need for service-wide scaffolding of practical resources to be in place, such as dedicated time, preparation and training for self-management. Factor 4 is an account that emphasises the importance of support provided when stroke survivors need it, and that professionals understand the needs of the individual and can tailor support accordingly. Combining Q methodology with realist evaluation provided 2 main advantages. 1, it provided a focus to refine the programme theories, and 2, it provided useful insights and hidden mechanisms beyond what might have been explored in traditional qualitative semi-structured interviews. Although each factor has distinctive features, a common element across all factors was the emphasis on a person-centred and individualised approach to supporting self-management. Also, a trusting and supportive relationship between stroke survivors and practitioners was prioritised across all factors. This helped us move forward with the programme theories in the rest of the realist evaluation by focusing on the individualisation of support and the importance of trust in the relationship between health professionals and stroke survivors. Also, we could see that factor 1 and 2 helped us to understand the values of supported self-management, so we could explore them later in the project. And factors 3 and 4 helped us to understand what resources and infrastructure may be needed to implement supported self-management, which helped us to explore implementation. Thus, Q helped to inform and guide programme theory development to tune into what were the key things to unpack in the programme theories. It's really important in realist evaluation to involve stakeholders in refining the programme theories, and other teams have used qualitative interviews and surveys, but here we've shown that Q has been an accessible method to engage a wide range of stakeholders and really helped us to focus participants' thoughts around priorities and contentious issues, and provided insights into context and valuable hidden mechanisms about how supported self-management was working in different areas. That's why we made all the adaptations to the Q sorting process. We're really interested to have a further discussion about the integration of Q into realist evaluation. We've raised a few points for discussion and we'd like to open up for questions and answers. Have you got any thoughts? There's no set standards on how it should be done. How does it resonate with you? Thanks for listening.